Vitality.
Vitality Unfiltered.
Unfiltered.
With David Bauder.
Welcome back to another episode of Vitality Unfiltered. I'm David Bauder, your host today. With me is Dr. Christopher Reeves and nurse practitioner Stephanie Lattimore. Today's conversation is menopause without fear. To get this started, we're going to start off right away with what menopause is and what it's not. And we're going to let Stephanie take that.
Thank you, David. What menopause is, by definition, and I know I gave this definition in an earlier episode, medically, menopause is defined as the absence of a period for 12 consecutive months. Now, this can be hard to pinpoint as perimenopause starts with changes in the cycle, so it can be hard to track. A better definition would probably be what menopause is not. Menopause is not just simply hot flashes. It's not a disease, and it's not a one-size-fits-all diagnosis or period in a woman's life. Menopause is a natural, gradual declining of the ovaries and a decrease in hormones.
I think that's well said.
That's about very good. Yeah.
I would say so. Menopause is a hormonal transition. It's not a character test, right?
Like
so
that.
It's like this old way of thinking that it's just a normal part of aging. It's a normal thing that everyone has to go through. I think we've talked enough about that on earlier episodes that, we don't have to, women don't have to suffer. Okay. So what are some of the common symptoms associated with, when we think about perimenopause, menopause, and postmenopause, what are the common symptoms associated with that?
You can have like brain fog, loss of energy, loss of libido, sleeping disorders or irregularities, anxiety. All of these things can be symptoms of that.
Perhaps some mood changes, mood instability, even joint pain and skin changes too. As the collagen changes, the skin composition can change as well.
Yeah. Did we mention sleep disturbance?
Yes.
Okay. All right. The one thing that comes up quite frequently, during the perimenopause and menopause is the vaginal dryness associated with intimacy, right? And keep in mind, like when you think about the treatment of that, right, that is one, regardless of risk factors, right, that can be treated with estrogen, right? We can use topical cream to treat specifically that concern. Additionally, when we think about menopause, and this is going to be a hot topic at this point, why has it gone untreated in the last 20 years? And this is where the Women's Health Initiative is going to come in. I'm going to let you take that and roll with it.
So back in the 90s, there was a study that was done called the Women's Health Initiative, and it was looking at hormone replacement in women. And, the study had several problems with it in terms of how it was interpreted. So some of the issues with it was that, initially in the study, there was the participants were given an oral conjugated estrogen and then a methyl hydroxyprogesterone. There was one formulation, one route, and one measure what was done. So
sort of like a one size fit all.
One size fit all kind of measure in this.
Right.
On top of that, the average age of all of the participants was 63 years old.
Oh wow. Okay.
So when you take all these things together, what happened when they started this study, they saw that there was an increase in cardiovascular, complications and problems, increase in breast cancers, increase in some of these side effects. And so the conclusion prematurely was made that hormones are dangerous. And so there was a whole generation of medical students, and providers who were scared and shunned off from even thinking about doing hormone replacement therapy. But it wasn't until more recently that there were a series of follow-up studies that were done that kind of teased apart this data and looked at it a little bit differently. One researcher, I think it was Joanne Manson, did a study where she had this timing hypothesis because of the fact that, we said that in the original study, the average age was about 63 for all these women. Well, her study showed that women who started and initiated hormone replacement therapy within 10 years of symptoms had protective cardiovascular, reduced of these side effects and these cancers and things like that. And then there's another study that was done that I there's a KEEP study that was done that showed that therapy that was, I believe that was the KEEP study or was the ELITE. I'm not sure which, I'm mixing them up. But one of them was looking at where if hormone replacement was given early, it was protective. And if it was given later, it wasn't as effective. Then what happened is as I looked at all this and started to realize that the blanket labeling of all hormones being dangerous was riddled in a lot of these issues that were teased out in later studies. And so as a result of that, the American College of Obstetrics and Gynecology and the Endocrine Society and all these different organizations, societies have reversed their stance on HRT and saying that it is beneficial.
Well,
but
the
it's
FDA too.
FDA as well. Yeah.
Just
So,
this year, I believe. Just this
couple
year.
months ago.
yeah. And so it's like it took a long time, a lot of this to kind of get this, reversed and kind of just have this be corrected in terms of the literature and the understanding and everything like that.
It's funny how things move slow, right?
Yeah.
So when you think about cigarettes and smoking, right? How many years did it take before it was really truly acknowledged? Everyone knew cigarettes were bad. Yeah. But it took them how many years to actually finally come out and say, okay, cigarettes are bad. Little black label, right?
Lobbyist.
Potentially, right? Okay. All right. That's fair, right? But this is the opposite, right? This is kind of like a poorly, and it does kind of, there's a lot of, I will disclose that when I did find out about this, I immediately went and looked about the study, and I wanted to know who the director was, and I wanted to I wanted to start peeling this back, right? And I immediately went and looked, okay, without saying names, right? Did this individual sit on any corporate pharmaceutical boards, right? I started really tearing it apart. And it looks clean, it looks like there wasn't no malice or anything behind the whole situation. It looks like everything was, it just was a poor run
design.
study.
It's a poorly designed study.
That's really what it comes down to, and everybody kind of just got on the bandwagon and just went with it.
Well, and like when we said in one of the earlier episodes about the difference between perceived risks and absolute risk and real risk, and this is one of those studies where the headlines came out about these early results, and then the media caught on to this, and then it just spread like wildfire. And then once that narrative got out there, it took 20, 30 years to kind of pull it back.
And we're just beginning.
to pull it back.
This is the beginning.
We're just beginning of pulling it back.
And as a patient and as a provider, it's hard not to, hear that noise and have that fear. If I were, prescribing hormones and all I had to go off of was this outdated study, but that was the most recent, largest conclusive study, I would be nervous too to prescribe.
And unfortunately, because this has been a whole generation of physicians that are out there that are afraid, now that these studies have come out, it's probably going to take another generation before it gets back online and becomes more mainline for multiple reasons. One, because of lack of education. So the younger doctors now are going to be trained, and providers are going to be trained on this. So that should help, but there's going to be a period of time where there's going to be still another number of women suffering unnecessarily because, one, in the traditional model, they don't have the time. We keep hammering this point over and over again. They don't have the time to really look into this. Seeing somebody once a year is not effective enough to really properly manage this sort of thing. And then just trying to replace the education within the field of medicine is going to take some time.
Yeah. And to properly manage these patients, and we'll get into what modern management looks like in a second too, is from our perspective, right, integrative functional medicine perspective, we believe in that it just isn't one estrogen hormone, right? It can also be by estrogen, right, where you are including the E3 hormone in there, and we do have the viewpoint that and this, there needs to be some shoring up of this to make sure it's conclusive. Certainly, we don't know of anything harmful about using the E3 hormone, right? But in integrative functional medicine, from a large perspective, they feel that the E3 hormone is additionally protective. So what do you do now with the reason I'm bringing this up is what do you do now when a patient is walking in, they're outside that window, the 7 years after menopause, right? The 8 years after menopause. Theoretically, that's past that protective time frame. They still are losing muscle mass. They still have fatigue and all of these things, and we're worried about their bone density. But even though we think we lost the window, right? We lost that window of opportunity. What do we use? Do we
It's a challenging patient population for sure.
Yeah.
But I would do just as comprehensive as an intake because there are options for those women.
Yeah.
There are.
It's just not the same
It's
as
just
somebody
not the
that just
same.
entered menopause.
Exactly.
You know,
Just as everyone in that study was not the same.
Right.
The 40-year-olds and the 70-year-olds in that study, although they were treated the same, they were not the same.
they were not the same physiologically. And you mentioned the cardiovascular protection.
Yes.
Like maybe elaborate a little bit. Like what is the, like we're talking about the blood vessels a little bit. Like what is that cardiovascular protection? That's
Well, when you have the estrogen, what it does is it kind of decreases the buildup of atherosclerotic plaques on the arteries. It is protective in that regard as well, which helps to reduce the risk for heart attacks, strokes, and that sort of thing as well.
It's somewhat my understanding that literally the lining of the blood vessel, the endothelial structure has changed. And so later on, if you go too late, then the estrogen no longer works effectively on that receptor in the blood vessel.
We can fact check this too. There was a cohort in that study of women in their 40s that actually had a decreased risk of breast cancer that were put on the hormone.
I believe it.
Yeah.
I believe it.
Yeah. Like a significant number of patients. So
Was that in which study was it? Where was
the health initiative, Women's Health
okay.
Initiative.
Yeah.
Oh, interesting.
Yeah.
The younger side of women had decreased rates.
Yeah.
But because they showed, so they had a cohort group of people, or they had a group of people that showed a benefit, but they just said
By
one
and
size
large.
fit all.
Overall, the relative risk of the cardiovascular and cancer and strokes was increased overall.
Overall.
But there was and then if the average age of the woman in the study was 63,
Yes.
I have questions.
Oh yeah. I mean, that's, right.
Yeah. Yeah.
So Steph, what does modern medicine look like today when we start talking about menopausal care? Like, what does that look like?
So modern care of the menopausal or premenopausal patient looks a little bit different in that each patient is taken as an individual. When I have a woman come to me who has perimenopause or menopause concerns, for example, I will do a complete intake, and that is really my best diagnostic tool, a family history, a personal history. That way I can do a risk stratification and see if BHRT, bioidentical hormone replacement therapy, is appropriate for this woman. So if I have a patient come in with an extensive family history of breast cancer, has not had a mammogram, maybe not the best candidate for progesterone and estrogen-based therapies, may still be a good candidate for testosterone.
Yeah, there's really not many known contraindications with testosterone.
So I would never just dismiss any patient based off of one piece of their history. It's really looking at the whole picture. Another patient may come in, no history of any breast or ovarian, uterine, any type of cancer in the family, no risk of stroke, has never had a stroke, heart attack, anything like that, healthy young female, has not had any unexplained vaginal bleeding, not pregnant or breastfeeding. Those are some absolute contraindications I would consider no-go. That woman would be a great candidate for hormone therapy, either progesterone, estrogen, and or testosterone based on her symptoms.
So it's very personalized.
Absolutely.
Modern menopausal care is thoughtful, personalized, and dynamic with lots of follow-ups. And to your point, you said modern medicine isn't really set up to see a patient every 3 months, repeat labs, make sure the hormones are on point. That's kind of the one-size-fit-all model.
Yeah.
Take this.
Yep.
And do you most of your patients, are you using compounded products or are you using retail products? Which way are you going?
For a lot of my patients, the majority, I'm on a compounded BHRT cream with a combination different ratio of the 3 female hormones, estrogen, which is can be biased, progesterone in the form of pills, a tablet every day, and testosterone.
Yeah, the cream mixed
The
in the
cream.
bias, or mix that with the. You're mixing it with the compound, or is that separate for you?
Depending on the patient, every patient's different, and it really takes the clinical picture. Labs are an important part of this, as we discussed. Every patient is different. Typically, a combination of compounded cream and progesterone pills.
Yeah.
Typically,
Yeah, it's a typical pattern that I usually see too. A lot of that, unless their risk factors are completely zero, right? Then I usually will I'll lean towards the patches,
Sure,
and go that route with the retail.
And each patient is going to have a preference too, and may have had a really positive experience with the patch versus negative. So it's really based on the patient preference. And that's something that her and I will agree upon in the consult.
Do you have any great patient care stories you want to share?
A few come to mind. I know I shared a woman in the last episode that I was able to improve upon her hot flashes and her sleep. I had another woman at the peak of her professional career. She was done having kids. She'd been in menopause for about 1.5 years, really struggling with brain fog. She said, "Steph, I'm groggy and foggy." And I put that right in her note. And I didn't want to normalize this, even though it is a symptom that a lot of women experience. She does not have to suffer. There are things we can do to improve upon her mental acuity and her sleep. We drew her labs. We did a very thorough and comprehensive intake. She was a great candidate, no risk factors at all. Not only did we help her sleep a little bit better, she found that with hormone replacement therapy, her mental acuity was much better, much less foggy in the workplace, had much more energy, not to mention a little muscle tone as a kind of a benefit of the testosterone. All the working out she had done had started to pay off in a sense. She had a little more definition in her arms. Mood was improved, libido. Now, it's not always perfect. There's definitely a balance, and I never promised the world, but I do want to improve upon these symptoms to help women feel better overall.
Yeah. I always try to tell patients, we're not here, like with any therapy that needs to be done, you're not trying to solve 100% of every symptom. You should really aim for that 85, 90% solution, because if you go for that last 10%, you're going to cause another problem.
Sure.
And, I'll share one patient real quick, and you've alluded to this about the right patient. It needs to be the right providers, the right clinicians. Just recently, I had a menopausal patient came in and she was prescribed a hormone cream, no pelvic ultrasound done, no initial blood work done. And I ended up checking her labs and, her estrogen level was 3 times the normal limit.
Wow.
And she had additionally all these other symptoms associated with that, with breast tenderness, estrogen dominant syndrome symptoms at that point. And so there is a lot of misinformation out there, right? There is a right way to do this, right? And I think it's just really important that when patients are out there looking for the provider, the clinicians that they're trying to have help with, right? Somebody's going to take the time to talk to you, do the intake, take all of your personal history, get all of the blood work that needs to be done. This patient didn't even have blood work done before they prescribed the hormone cream. I mean, I'm like sitting here and I just scratch my head.
Yeah,
like
it's bad medicine.
Yeah, it is.
Yeah.
I mean, it's just like that
Scary.
doesn't even it doesn't make sense, and no pelvic ultrasound done, right? And these are just preventive things that you're doing because no treatments are risk-free. Yeah. There's risk associated with everything, and you just are minimizing the risk with proper monitoring and surveillance and follow-ups.
And nobody said it was easy.
No.
Right.
But if you have the time as a provider and the resources and you're willing to put that in and you can listen to your patients, you can help them.
Absolutely. Well, team, I think that wraps it up for this episode of Menopause Without Fear. I want to thank each and every one of you out there listening to this show today. If you like the episode, make sure you click the subscribe button or the follow-up button so you don't miss the next episode. And until next time, this is Vitality Unfiltered.
Thanks for joining us on Vitality Unfiltered with David Bauder. Addressing norms, busting myths, and uncovering health realities for a more vibrant life today. For more expert insights and real talk, make sure to subscribe and join us next time.